Welcome to Techniques in Coloproctology's fourth virtual session. This one is on proctocolectomy for ulcerative colitis and is presented by Paulo Kotze and Sven Flemming, moderated, of course, by our Editor-in-Chief, Rodrigo Perez.
Welcome everyone to the Techniques in Coloproctology virtual session of the month. Today we're going to have Dr. Sven Flemming from Würzburg. He's going to talk about his paper. It's been published recently, Techniques in Coloproctology, and talks about real-world data on patients with ulcerative colitis being managed by 2 or 3 stage procedures. Thanks very much, Sven, for connecting. I know it's very late in Germany now. We appreciate you presenting here, and congratulations for your paper. And following Sven's presentation, we'll have a couple of comments by Paulo Kotze, who's also an expert in IBD and is currently in Curitiba, Brazil, and will give us some insights on the topic and on Sven's talk. And then we'll have a few questions from the audience, and I invite everyone to send questions either in English or in Spanish or Portuguese, whatever you would like to send us questions. We'll be happy to address them. So Sven, thanks again, and please go ahead. The floor is yours.
Thank you very much for the kind introduction and for the opportunity to present our paper and our data. You can ask also in German if you want, but I think there are not so many Germans. So, I think every one of you knows that the incidence of inflammatory bowel disease and ulcerative colitis are increasing, not only in Western Europe or the US, it's all over the world. And so we have an increasing burden, not only for patients, but also for us as a healthcare systems. And almost every month as a surgeon, you think almost every week there's a new medical option, new biologicals, new treatment options. But if you look on the operation numbers, it's still stable over the years. So ulcerative colitis, there's still a big need for operations. And you have to keep in mind that in comparison to Crohn's disease, UC can be cured by us surgeons. So I think we should keep it in mind that it's really a relevant therapeutic alternative to all these new medical treatment options. What are now the current challenges? So the proctocolectomy is usually the treatment of choice if you have a medical refractory disease or if you have dysplasia, a malignancy. And if you are performing the proctocolectomy, the aim is almost to create ileal pouch anal anastomosis. However, if you're looking now to the literature, the evidence is not very, very strong, and you have a lot of studies with heterogeneous conclusions. So that's why we were performing our study to see and to evaluate what are our results of the last 10 years. But looking now first to the European guidelines, for instance, you see here it is published 2 years ago by Spinelli and the ECHO surgical group that you have different options for surgical treatment of UC colitis. You have a single stage restorative procedure or non-restorative procedure. I think this is not very common that you are performing a single stage operation. Then you have this 2-stage, and in the last years there was a trend to the modified 2-stage procedure, and you have the typical 3-stage procedure where you're performing a total colectomy followed then by a restorative proctectomy with ileostomy, and then this 3rd step is the ileostomy closure. If you are performing this 3-step procedure, normally the rectal stump is blind closed and you have an ileostomy, And the result is then for the second operation that you maybe can find then postoperative adhesions in the small pelvis because you have been operated already there. And maybe the access to the remaining rectum, to the rectum stump, is limited and it's more difficult to operate there and to perform or to create the ileal anal pouch. This adhesion and persistent inflammation makes the second step then more complicated. That's why we have a modified surgical approach here in Würzburg. So when we are performing a three-step operation in patients suffering from ulcerative colitis, we will do in the first step a subtotal colectomy, performing a ileostomy and a sigmoidostomy. You can see it here in figure B. The advantages of this approach is that you don't touch the small pelvis. So in the second operation, the small pelvis is totally fine. You don't have any adhesions. And the second advantage is that you can apply very easily a local treatment due to the sigmoidostomy. So you can stop all systematically steroids or biologicals, but you can still treat the West colon via the sigmoidostomy. And you see then when we are performing the second operation, we will remove the rectum and the colon sigmoidium and perform the ileoanal pouch anastomosis again with a protective ileostomy. And then in the third step, there is the loop, the stoma closure, as you have it also in the normal way as recommended by the European Crohn and Colitis Organization. So what was now our study? So we had a single center observational retrospective study, and we included all the patients older than 18 years old, which were operated between 2010 and 2021. And at least all our patients had a follow-up at 12 months. And the indication for inclusion were ulcerative colitis, either with dysplasia, malignancy, or with medically refractory disease, or in an emergency case like toxic megacolon. And all the patients were discussed pre or post-operatively by interdisciplinary IBD board, including gastroenterologist, surgeon, pathologist, and radiologist. The aim of our study was to evaluate the morbidity between two-steps and three-step approach. And secondary endpoints were length of hospital stay, operating time, days with stoma, because we think that is or has a big impact for our patients. And then, of course, the rates of successful stoma reversal, so stoma closure. Here you can see quickly our patients' characteristics. There are no so many difference regarding age, BMI, ASA classification, smoking, or other cardiovascular risk factors. But as you can see here, of course, the main part of a patient with a two-step approach were operated due to malignancy. And in the three-step approach group, there were more patients with refractory disease. So they had more biologicals, they had more steroids. And when you are looking now on the preoperative state regarding hemoglobin and albumin, and also biological and steroids therapy, you see significant differences between these two groups. Coming now to the primary endpoints. So in the operating technique, we didn't have any differences between open or laparoscopic approach. And what you can see now, the CCI score and the Cleveland-Dindo score, here we haven't seen any differences between these two approaches. That means that also this 3-step and 2-step approach is a very safe procedure if you're doing it in a high volume center. And there were no differences even in the rate of anastomotic leakage, even if the patients with a 3-step approach were initially more in a malnutrited state. Again, here you see the big differences between the hemoglobin and albumin pre-surgically, but this difference was only before the first part of the surgery. So in the group with a 3-step approach, we had a normalization between the first and the second step. So the hemoglobin and albumin levels were on the normal level before this second step was performed in the 3-step approach group, and was comparable to the group where we have done the 2-step approach. So now the question, how long are the days in the hospital, and of course the operating time on days with stoma? I mean, I think you can imagine that if you are doing 3 operations or 2 operations, there's a longer hospital stay, and maybe also a longer stay at ICU, and also the operation time is longer because you have to do 3 operations. But interestingly, the days with stoma was not significantly longer, but the difference was at least more than or almost 80 days. So it's not statistically significantly, but maybe important for the patient. So now the question, how successful was the stoma reversal? And as you can see here, the stoma reversal was significantly more often performed in the 2-step approach group than in the 3-step approach group. And the question was now why we haven't performed so many times the stoma reversal in this 3-step approach. And one of the most reasons was that the patient didn't want to remove the stoma, so they didn't want the stoma closure, because when we asked these patients, they said that now their quality of life was so significantly increased after the colectomy and the proctocolectomy compared to preoperative, so that they didn't want that the stoma is removed, because they were fine now with this situation, and they were afraid that maybe after stoma reversal they have again 5 or 6 stools per day, and maybe they are not they cannot hold the stool sufficiently, so they had the wish to keep the stoma. That was really surprising for us. So I think the take-home message is that the 3-step proctocolectomy with creation of the sigmoidostomy is a safe procedure and reasonably as a surgical approach in patients with high dosages of immunosuppressive medication or other risk factors such as active inflammation and anemia. And I think you could see that we had comparable rates of postoperative complications, so the morbidity was almost the same. And you have to keep in mind that the rates of stoma reversal is almost significantly decreased in the 3-step approach group, but the reason was that mostly due to patients' request. So this is this nice summary which was created from techniques of coloproctology, and I'm happy to take any questions. Thank you very much for your attention.
Thank you, Sven. I think I'm going to turn over to Paulo to make his comments. I just want to make you a couple of questions before Paulo addresses some of the issues that you've nicely covered. And of course I've read the manuscript in the final version, so I probably have that information. But I wanted to ask you about intervals in terms of interval times between each of the procedures, both in the 3-step and the 2-step procedure. So what was the average intervals between the procedures in each of the studies groups?
Yeah, so we are waiting. So in the 3-step approach, we are waiting between the first and the second operation. We are normally waiting 6 months.
Okay.
And then from the second to the third operation, or from the first to the second operation in the 2-step approach, we are waiting 3 months. But maybe you can also wait there 6 weeks or 4 weeks, or you can perform the stoma reversal also after 5 days if you, or 7 days if you have checked that the anastomosis is fine. I mean, I think that depends also on your healthcare system. And to be honest, in Germany, you have the problem if you're performing the stoma reversal on the same hospital stay, you are not paid for it. So, I mean, this is very sad, but this is the system, and that's why in Germany you say, okay, let's do it after 6 or 8 weeks, because then you get the money again from the healthcare insurance. That's the reason. But if you are fine with anastomosis after 5 or 7 days, you have checked it endoscopically, you can do the stoma reversal also after 5 or 7 days.
Okay.
I think more important is the interval between the first and the second step, when you have high dosages of immunosuppressive medications, and you have a patient with bad conditions, anemia, low levels of albumin.
Yeah, and then I mean, I think that both doing the first operation on an emergency setting,
Yes.
or high levels of immunosuppressive agents and so on, the long or rather long intervals are actually quite convenient in terms of getting the patients back into an appropriate situation for them to undergo this second step of the procedure. And I think you quite nicely showed that in your study. So yeah, thank you very much. I think, Paulo, I think you can go ahead and give your thoughts on this, and then we'll go from there.
Thank you. Just please confirm if you can see my slides. I just prepared a couple of slides first. Yeah, perfect. So thank you, Rodrigo and Sven. This was a fantastic opportunity for us to discuss the approaches that are used for surgery in ulcerative colitis in 2024. And I think the relevance and the impact of papers like Sven's paper, they are pretty impactful in our clinical daily practice, because what we see is that a good surgeon must have all the options on board and choose accordingly. I think this is one of the main messages. So as we see, and Sven also presented that by the ECHO guidelines, the steps that are needed to a complicated operation such as the restorative proctocolectomy with IPAA, this complicated procedure, technically speaking, needs deviation. So proximal stoma deviation is a must, according to the majority of authors throughout the globe. And I think you don't see surgeons, except from the pediatric surgeons, doing one stage IPAAs at the current point, even for polyposis. So I think protecting with the stoma is the first message that this paper and also the literature gives to the audience. It's a must for these patients to protect distal anastomosis. And of course, a proximal stoma does not avoid a leak, but it prevents a clinically significant leak. And of course, we have now this modified 2-stage defended by Europeans, people from Belgium and the Netherlands and the UK. They are doing a second operation, excising the rectum with the proctectomy, performing transanally this proctectomy, giving these patients TTSS-like anastomosis from the pouch, and not protecting them with the loop ileostomy. And I think with that, their strategy is to put a Foley catheter into the pouch and check the CRP levels in a daily basis. And if patients increase their CRP and eventually they have a suspicion of a leak, they just inject some contrast in the pouch as a pouchogram, and then they can drain and put a stoma in this patient. So they think that they can avoid stomas in patients in terms of 80% of the patients. And again, the 3-stage for patients who are sicker. And I think what I want to show to you by now is that probably indications for colectomy in UC are changing a little bit. And you could see by Sven's data that several patients had malignancy. And what we see now is, as he said, that not every week, I would say, Sven, but maybe every 6 months we have new medications for UC. You're right on saying that. So we have more and more options, and the more recent drugs, they work quite well. And with that, you get more disease control. So patients, they have mucosal healing, and they have a long-lasting UC. So we're now seeing patients with 20 years of disease, 25 years of disease. So these patients keeping time with their columns, they have a higher chance of developing high-grade dysplasia, which leads to colectomy. And if you're operating a patient with malignancy or high-grade dysplasia, who is stable, he's not in biologics, not anemic, not malnourished, 2nd stage or 2-stage operations are the proper strategy for these cases, according to the literature. And also you could see a pure reflection of this in the data set that he just presented. And again, there's another thing, that probably insistence or persistence with different types of drugs. And if these drugs do not work, these patients are in trouble because they will have a surgical delay. The gastroenterologists probably, they want to spend more and more time trying drugs to these patients. And we're going to receive those patients in a worse condition. They are marinated with steroids. They have a lot of malnutrition on board, anemia. In these cases, you could see that patients are sicker. And again, 3-stage procedures here are safer for those patients. And you could also see that dysplasia cases are increasing globally. This is data from Asia, from South Korea. And you could see a video with a dysplastic case from our unit on the right-hand side. And if you see data from the Netherlands in a national level, you definitely can see that from the early 90s up to the late 2019 to 2020, there's an increase in indications for surgery in ulcerative colitis at a national level for malignancy. So colorectal cancer and high-grade dysplasia comprise a higher proportion of patients currently than it used to be in the decades ago. So I think this leads for us a lot of thinking and a lot of discussion for us to try to understand what's going on with UC in the surgical management. So in terms of the data set that Sven presented, the data set is very complete, and people usually think, well, this is not a good number of patients. So if you have 50 patients and a good sample, and the way you documented all the variables, you could check some differences on that. So first of all, the standardization of the data collection, we have to congratulate your unit, Sven. Maybe I do not agree as much to say that we can cure all UC cases with the pouch procedure. So this is probably something to discuss, because 50% of patients after 10 years will have pouchitis. A small proportion of patients may have extraintestinal manifestations that are not related to disease activity, and these patients still can struggle with UC. So the word cure for us maybe highlights some attention. I'm not sure if you agree with that. Maybe if you want to contribute for this discussion, Sven.
Yes, I'm agree with you. I mean, of course, we see also this patient with pouchitis, and unfortunately, sometimes then the diagnosis is also changing, because initially we were treated as patients with the diagnosis ulcerative colitis, and then maybe a couple of years later, we have also in the small intestine inflammation, and then it comes out that it's more a Crohn's disease, or was a Crohn's colitis than an ulcerative colitis. So that's why I'm agree with you. Cure is maybe too strong, but
not for all patients.
We are almost so good or as medical treatment, right?
Yeah, I understand. And another important point from the strategy that you guys use when you do, for example, a 3-stage procedure is the high mucus fistula of the sigmoid. Okay, so you exteriorize as a mucus fistula in the sigmoid. in order to be safer, or to leave the pelvis intact.
Yeah.
So another thing that we can discuss here in this 2 versus 3 procedures is the management of the rectal stump. So I do believe that in urgency setting, when you're operating acute severe ulcerative colitis, and you have those friable colons, I think the strategy you present is perfect, because you can then reduce a lot the rates of a rectal stump fistula, or a leak of the
Yes.
closed rectal stump. So some authors, they defend the position to place it in the subcutaneous. I don't like to do that personally. I think it's not a good strategy. So usually what we do is we try to close it and to put a pelvic drain on it, and even an intrarectal drain to decompress it. And usually we can check it. But this is in the cases that where you have like a good, let's say a good rectum, not a friable one. So, but if you have a friable rectum, I think to exteriorize the mucus fistula is a perfect indication. And if you don't want to do that, the recommendation would be to leave the pelvis intact and close the rectum at the level of the promontory site. So do you, for example, when you do total colectomies for stable patients, do you always do that? Or even if you have so those cases that you can close the rectal stump?
No, I mean, if you don't have a fragile rectum and the patient is in a good shape, we would prefer the two-stage approach, right?
So you do the two
we
stage.
are using only the three-stage approach currently for patients who are in bad conditions and have a high level of inflammation. And that's why we are using the sigmoidostomy, what you said, that because we are afraid for the stump leakage, abscess, even if you have then a transrectal drain. I mean, this makes more difficult for the second operation when you have to perform then the pouch. And I think the pouch is the most important step for quality of life for the next 10 years, 20 years of the patient.
Yeah, I fully agree with you. And also this is very impactful. So clearly when we check your data set, when you have the interval of time and the number of patients that were included, the patients with 3-stage procedures, they were sicker.
Yes.
They had low albumin, more anemia, malnourished, and probably those patients, they have like medical refractoriness as an indication.
Yeah.
At the other side of the coin, patients with malignancy who are quite stable, mostly they were having 2-stage procedures. But one of the things that I want to stress here is that now we have a lot of data showing that the ones to blame in complications and the way you're going to perform like defensively when you do a surgery, a surgical operation for UC, are steroids, low albumin, and also anemia. And again, the patient's drugs are not the drivers of complications. They are coincidental factors. So we have now data with serum levels of anti-TNFs, data with vedolizumab, and also data with ustekinumab, anti-interleukin. Those are not the ones to blame. Usually they are done in sicker patients, but biologically, nobody proved up to date that these are the ones to be blamed. Some papers, they do that in multivariate analysis, but the majority of papers, including the prospective Puccini trial, they just conclude that we cannot blame the drugs. And I think this is an important message, because some people are seeing patients that are quite stable and well, but if they're having, for example, infliximab, they're going to do 3-stage. It's not the case. It's not about the drug. It's about the condition of the patient. I'm not sure if you agree with that.
Yes, I agree with you. But yes, I totally agree with you, but I think that the 3-stage approach is when the gastroenterologist is trying steroids, antibodies, the next antibody, and no antibody works, right? I think this is then you have the sign, okay, there's a high level of inflammation, and even drugs are not helping. And that's why we are doing this 3-stage approach. I totally agree that the antibody is not the reason for post-operative complications.
Excellent. So my last comment, Rodrigo, and then I'll give the word to you to open for questions from the public, would be regarding tips and tricks before ileostomy closure. I think this is really something that people are not doing maybe the way it should be done. Because sometimes you can have a silent small leak in the IPAA, and if you don't check it properly, you can simply, close the ileostomy and have a big problem at the end of the day. So, any personal tips and tricks that you use then before ileostomy closure to check if the pouch is okay and if the anastomosis is okay?
So we are performing a endoscopy, and the endoscopy is done by ourselves, so by a surgeon, because we know where how it has to look, and so we also do a pouchogram. But the pouchogram is sometimes the problem is that the radiologist is putting the drain too much into the pouch, and so you don't see the anastomosis. So that's why I think the most important thing is the endoscopy, and you should do it by yourself to check your anastomosis by yourself.
Excellent. So I do the same. Usually I check my patients myself. I use a gastroscope, and then you can usually do the retroflexion as well inside the pouch. And I think the retroflexion shows you very nicely the way the anastomosis is done. And if you go for a pouchogram, I do believe that 100 milliliters of iodine is enough for us to check. But as you said, the radiologist needs to inject it not at the apex of the pouch, but at the bottom of it, close to the anastomosis, in order to try to see.
But you have to talk to your radiologist, because sometimes then this is younger and hasn't done it before. He puts a drain into the pouch. It's blocking the drain, and then the block is there where the anastomosis is, and you don't see a leakage if there's a leakage.
Perfect. And I think Diego asked if the pouchogram is by MRI. Usually we can do it by MRI or CT scan. I think those are the best possibilities to do that. So Rodrigo, the screen is now yours, not the floor. And I think we can still be here for contributions, and let's see what people come with questions.
Sure. I have a few questions myself. First question is, I heard you guys talk about rectal drains, intrarectal drains, particularly when you think about closing the rectal stump. My question is, I imagine that we're talking about a 3-stage procedure when you're doing this on an emergency setting, or the patient is under high doses of steroids and so on, and immunosuppressive agents. You end up doing a closure of the rectal stump. And then do you always leave a rectal drain within the rectum? For how long and what kind of drain? Can you both answer the questions the way you guys do it, please?
So if you have creating a rectal stump, we are always insert a drain. It's like an easy flow drainage. It's small, and we are keeping it for 4 or 5 days. And then if the CRP very low, we can remove it. If the CRP is going up, we will perform endoscopy of the
What kind of a drain?
We call it easy flow. It's like a silicone drain. It's very easy, and we put it there for 4 or 5 days. I think
whenever you do a mucous fistula with the sigmoid, there's no need for drains, correct?
No, there's no need.
No need for drains. Yeah, this is in consensus. Rodrigo, I just want to add that whenever we use intrarectal drain for a rectal stump, or an intra-pouch drain for compression of a pouch when you do the anastomosis, usually we leave it there for 2 to 3 days. And again, if patient is doing well, CRP is fine, and we can take it out, because there's no transit on that, and I think it works quite well. Usually you can use a Foley if you want, a large Foley, but the mushroom catheter, I think it's probably better. I'm not sure if you use it as well.
So you use it, you both. So when you do a 2-stage procedure, you leave the drain within the pouch itself, and also
not in all cases, I would say.
No.
not in all cases.
No.
Okay.
Usually when you do a modified two-stage, when you don't want this patient to put an ileostomy, you perform the pouch and you don't give him an ileostomy. This is the experience from Belgium, from the Netherlands and the UK. They leave an intra-pouch drain for 3 days and then they test it with contrast and then take it out after 3 days.
Okay. And the other question is really just to make sure. It seems to me that patients who are candidates for two-stage procedure or three-stage procedure are entirely different. It means that we are never going to have a true comparison study between the 2 and 3 stage because the patients are simply different from each other. So considering the fact that we're treating more and more patients with medical treatment and we're doing less elective operations for this, proportionally speaking. Of course, I understand that we're doing more for malignancies, but I think in numerically speaking, we're doing less pouches on the elective setting than we are in terms of the emergency setting. So do you think we're going to move to, more people be doing the 3-stage procedure than the 2-stage procedure in the very early future?
No, I think so. As my experience is now in our center in the last years that we are performing more 2-stage procedures because we see more patients with dysplasia malignancy and less patients with high inflammations. So this is getting less and less. And I think also when you discuss the operations, these patients are totally different because the patient with dysplasia malignancy, they haven't suffered from the same symptoms like the patients who need a 3-stage procedure, because the patient with 3-stage procedure, they had a really high burden of inflammations. So they had more pain and all this stuff and bloody stool. So that's why I think also that these patients, also in our cohort, they were already happy that they had now a stoma and they didn't have pain anymore and this low quality of life. So they were again already happy with this stoma. The patients with malignancy, they don't have really problems. So the stool is okay, maybe sometimes a little bit pain, but they are almost like normal patients, right? Like patients with colon cancer. And that's why they don't accept a stoma like the other patients. So, and in our center, we see more patients with malignancy, and that's why we are performing more and more 2-stage procedures.
I think, Rodrigo, for our reality is a little bit different. We are seeing still a lot of sick patients because we don't have access to all drugs in the public setting mostly. So we are seeing still a lot of 3-stage procedures, need for 3-stage procedures, mostly because we still operate some patients in the acute setting. So patients with refractory disease not responding to rescue therapy. And those patients are often always going for 3-stage procedures. And so I think in the near future, maybe 10 years from now, we'll see much more dysplasia in colorectal cancer in IBD patients than we are seeing now. This is my impression.
Okay. There's another question from Greece. Leonidas Kardalias, I'm sorry, has asked both of you, what do you do when your rectal stump blows out? How to manage it, considering future pouch reconstruction?
That's a good question. Huh? So usually prevention is key. If you don't have a drain there and it blows out, you have an abscess, you do percutaneous drainage and try to cool down the sepsis and put a drain on it. And I think that's the number one question. And then the future IPIA will already be difficult. I think we are in consensus on that. In some cases, what I did, I'm not sure if Sven had the same experience. So in some patients, you can come from below, you can do a rectoscopy with a gastroscope. You see the opening there, and then you just open the pelvic space that is blocked by the abscess. You just clean it out from below, and then you put a sponge in there or even a drain, and then it transrectally it's drained, and it makes your abdominal wall, let's say, a little bit protected for the next procedure. So usually this is the way we do antibiotics, percutaneous or transrectal drainage.
Yes, we are doing the same. So rectal drainage. So we are putting then 2 rectal drainage that we can flush one drain to do like lavage. Or if we are sure that we don't have a problem that that we have direct contact to the small intestine, we are also inserting a sponge, like a sponge therapy, with to drain also the abscess and to close the rectal stump with negative pressure.
Okay. And my final question to you both: when you do a 3-stage procedure, you're only doing the proctectomy at the second stage. Do you do it transanally with the how do you approach that? What's the best surgical approach to the proctectomy only in the patients you've done? You're doing a 3-stage procedure.
We are doing it by a robot. So, and then if you are okay, we are keeping a cup of 0.5 or 1 centimeter and doing a stapled anastomosis. If it's fine from inflammation and from dysplasia, we think that the stapled anastomosis is better than the Hansoon anastomosis. Then we can come only from abdominal by a robot, because I mean the advantage of the robot is you can go very deep, and you have a nice view, and it's perfect. I mean you can dissect it to the pelvic floor and also to the anus, so it's perfect by robot.
In our experience, Rodrigo, just to add, we have done some transanal cases, but we didn't have easy access to the platform. So most of our cases now are being done laparoscopically or robotically with double stapling anastomosis as well.
Okay, so I still remember a number of places doing this laparoscopically with a single port at the site of the ileostomy. And so you think with the robot and even laparoscopically, it's a better alternative to staple off the rectal stump and the cuff through the abdomen instead of doing transanally. Is that correct for both of you?
Yes.
Yeah.
Okay. Final question. Abel Quaresma is asking, what is the main risk factor that leads to the decision to have a 3-stage procedure? I mean, what would be, absolutely no-brainer indication for a 3-stage procedure rather than a 2-stage procedure? Go ahead, both of you.
Maybe in my experience, I would say a combination of steroids and malnutrition and high inflammatory burden as well. And this is you see in these patients all the time.
Yes.
Okay.
I'm agree.
Okay. Diego Bertani asked, do you go in the TME plane for the proctectomy, or do you go close to the rectal wall for the dissection of the rectal stump? Sven, what's your preference? And then Paulo.
I prefer the TME plane because I'm not afraid for the plexus or for the nerves, because by robot I can see it very nicely, and when I'm in the plane, there should be not a problem. And I think if you have that inflammation and you're not in the plane, it's getting very bloody. It's going not to be nice. And I mean, then if you are leaving all this fatty tissue, especially when you have a man So there maybe you don't have enough space then for the pouch. So that's why I prefer to go in the TME plane.
TME.
Yeah,
Yeah. Paulo,
I agree.
go ahead.
I agree. Robotically or laparoscopically, up to down, transabdominally, TME. However, if you do transanally, you can do for closed rectal dissection. It's easier for you to do transrectal dissection, not a TME style, and do transanal.
I still remember, please correct me if I'm wrong, I still remember a randomized control trial,
Yeah.
TME
From the
versus
Netherlands.
yeah. And
Yeah.
and
And it was
this,
interrupted. The trial was interrupted because the results were much better from non-TME, and they do a lot of closed rectal dissections there.
Yeah.
Because of that trial. Yeah.
Interesting. But doing through the TME plane or following the TME plane is not a sin in when doing a IPAA pouch, correct? Interesting.
Without dysplasia or cancer. Without dysplasia or cancer, it's right.
Well, yeah, definitely. When there's rectal cancer, there's obviously an indication. All right. I don't think there are any additional questions. I want to thank you both for the incredible session. I've certainly learned a lot myself. Thank you, Paulo, for the insightful comments. And Sven, congratulations on the study. I think it's a very interesting study. I have one final question before we hang up. And my question is, what are you guys thinking about next? What is going to be your next study on IBD? We're looking very much forward to that.
So I mean, so our next studies here, they are going more to Crohn's disease, and of course, what everybody is doing, Cono S anastomosis, or lateral or end-to-end. So we are involved in the study started by Professor Mechilasti from New York, the Cono S trial. So we are participating there, and so now we had the first results of it. I mean, it was presented last time at the ECHO Congress. So there we are focusing now, and then maybe going back to the colitis. I think maybe there are still open questions for colitis, more for Crohn colitis. What kind of anastomosis are you performing in Crohn colitis when you are doing segmental dissection? So it is also end-to-end, like you maybe perform it when you have a normal colorectal cancer, or it is also side-to-side or Cono S. So I think there are some open questions, especially for Crohn colitis.
Okay, thank you very much. We're very much looking forward to your next research project. Congratulations again.
Thank you
Thanks
very
for
much.
connecting. And Paulo, thank again. Good night, everyone.
Bye-bye, guys.
Good night.
And we'll
Bye-bye.
keep you posted for the next Techniques in Coloproctology virtual meeting. Goodbye, everyone, and see you next time.
Bye, guys. Thanks.
Thank you for watching. Be sure to subscribe and join us for our next virtual session here at Techniques in Coloproctology.